Airway disorders. Congenital symptoms. Symptoms depend on the underlying malformation and its location. Patients may be asymptomatic cough, wheeze, dyspnea, stridor, hoarseness, dysphagia. Signs. Physical findings depend on the underlying malformation and its location. Examination may be normal, decreased breath sounds, rhonchi, rouse or dullness to percussion over the area of the malformation. Fixed or unilateral wheezing, stridor, hoarseness, respiratory distress. Investigations. Chest radiograph, useful for localizing the malformation, frequently obtained for other reasons, with a congenital lung malformation being an incidental finding. Both post-anterior and lateral views are needed to localize the malformation. Chest computed tomography scan, also useful for further delineating the malformation and for viewing its internal structures and its relationship to neighboring organs. Barium swallow, useful for determining if the malformation is compressing nearby gastrointestinal structures. Airway films, to assess airway caliber. Chest magnetic resonance imaging scan, useful in cases of pulmonary sequestration to identify the arterial feeding vessel or to identify and better define cases of arteriovenous malformations or anomalous vascular structures. Angiography, useful in cases of pulmonary sequestration to identify the arterial feeding vessel or to better identify arteriovenous malformations or anomalous vascular structures. Bronchoscopy, useful for assessing airway patency and dynamics, for identifying interluminal lesions or extrinsic airway compression, and for removing foreign bodies. Complications. Bronchial compression, with secondary atelectasis or recurrent or chronic pneumonia. Respiratory distress can be due to compression of the airways or surrounding lung tissue or from a hypoplastic lung. Hemoptysis, esophageal compression with resultant dysphagia. Note: many congenital malformations of the airway have accompanying congenital malformations of other organs. Differential diagnosis. Extrathoracic malformations. Laryngomalacia, subglottic stenosis, laryngeal web, laryngotracheoesophageal cleft, subglottic hemangioma, tracheomalacia, tracheal stenosis, tracheal compression secondary to avascular malformation, i.e., vascular Ringer sling, tracheoesophageal fistula, interthoracic malformations. Tracheobronchomalacia, aberrant right upper lobe bronchus, pig bronchus, arteriovenous malformation, bronchogenic cyst, pulmonary cyst, cystic adenomatoid malformation, pulmonary sequestration, congenital lobar emphysema, hypoplastic lung, congenital diaphragmatic hernia. Miscellaneous laryngeal papillomas, mediastinal masses. See mediastinal masses. Pneumonia, tuberculosis with a cavitating granuloma, secondary bronchial compression and resultant atelectasis caused by foreign body, hilar adenopathy, cardiomegaly, bronchiectasis, cystic fibrosis, lung abscess, pneumothorax. Dependent on the underlying malformation, however, in general, most of these congenital lesions are rare. Treatment. Diet and lifestyle. No specific dietary or lifestyle changes are required. Pharmacologic treatment dependent on the underlying malformation. Antibiotics, if infection is present, i.e., pneumonia, tuberculosis, lung abscess, steroids or interferon, can be useful aids in treating airway hemangiomas. Non-pharmacologic treatment dependent on the underlying malformation. Surgery, to correct any vascular anomaly or to remove the malformation, i.e., bronchogenic cyst or pulmonary sequestration. Tracheostomy, to maintain the patency of the patient's airway. Embolization of isolated arteriovenous malformations, an option in select cases. Observation, Sometimes an option if the malformation is benign and delay in treatment will not adversely affect the outcome, i.e., select cases of congenital emphysema or smaller airway hemangiomas. Treatment aims to alleviate symptoms. To maintain a patent airway. To treat underlying pathology. To prevent reoccurrence of lesion. To prevent recurrent infection. Secondary to bronchial obstruction. Prognosis depends on underlying malformation. In laryngotracheomalacia, the prognosis is excellent, with most patients outgrowing their problem by 2 to 3 years of age. In airway hemangiomas, most spontaneously enveloped by 3 years of age. In most congenital lung malformations, the prognosis is excellent if the lesions are removed before recurrent infection becomes an issue. In congenital lung malformations, which have a propensity to expand, congenital emphysema, cystic adenomatoid malformations, if expansion is occurring and causing respiratory distress, delay in surgical removal is associated with a poor prognosis. Follow-up and management in isolated malformations. Follow-up is short-term. Chest radiographs and pulmonary function tests can prove useful for following pulmonary involvement.